So, wish you all a very good evening, respected seniors and my dear colleagues. With your permission, I begin the presentation of my topic titled The Linagliptin plus Empagliflozin for Glucometabolic Benefits and Optimum Cardiorenal Risk Reduction in Your Patients. That's the acronym for Legacy. Evidence to experience sharing early use of the Empalina combination, fixed dose combination in patients with type 2 diabetes mellitus. Now, any discussion pertaining to type 2 diabetes mellitus falls well short of its intended idea unless we are truly assessing the huge global and the Indian burden that is diabetes mellitus. Diabetes mellitus, unfortunately, a disease that never sleeps, essentially meaning no matter how well you control your patient of diabetes, no matter how beautifully compliant your patient is to the pharmacological and the non-pharmacological advice, no matter how well the drug acts, no matter how compliant your patient is to your drug therapy, the disease is going to get worse. The hepatic gluconeogenesis is going to increase. The insulin levels are going to fall. In fact, not even at the diagnosis of type 2 diabetes mellitus, but even at the point of pre-diabetes, the patient has already lost 50% function of the beta cells of islets of Langerhans. And not only that, the dreaded macrovascular complications of diabetes mellitus not only begin at the point of definitive diagnosis of diabetes mellitus, but at the point of pre-diabetes. The world has 425 million diabetics. 2017 IDF data around 430 million diabetics. 2019 IDF data. India has approximately 77 million diabetics. The projections are even worse. By 2045, the world is expected to have around 700 million adult diabetics. India by 2045 is expected to have around 134 million adult diabetics. In the next few decades, not only India and China and our neighboring states like Pakistan and Bangladesh will contribute majorly to this huge diabetic burden throughout the world, including but not limited to the United States, but also the poorest of the poor nations, nations from the sub-Saharan Africa, they are also going to see a huge surge in the number of diabetics aided with rapid urbanization in the next few decades. And how bad is the Indian scenario? If you have 100 patients with diabetes in India, only 15 patients out of 100 patients in the Indian scenario have well controlled diabetes. 3 patients as such who have uncontrolled diabetes, at least they are aware of the fact that they have uncontrolled diabetes. So 15 plus 3 is 18. 32 patients are such who know that they have diabetes, but they are not aware of the fact that they have uncontrolled diabetes. So 15 plus 3 plus 32 is 50. What about the remaining 50? The remaining 50 patients do not even know that they have diabetes. They are undiagnosed diabetes, and that is not only the case in India, a third world nation, that is the condition throughout the world. 50% patients throughout the world are undiagnosed diabetic, and what is the Indian scenario? Only 15% of Indian adult diabetics have well controlled diabetes. Now, India doesn't have 100 people with diabetes. India has 77.1 million people with adult diabetes. So with this understanding of this huge burden of diabetes and the macrovascular complication of diabetes that India is facing and projected to face an even larger collapse over the next few decades, we delve further into our discussion. What is the interrelated disorders of diabetes? So it's diabetes mellitus and the metabolic disorders associated with diabetes mellitus. It's like a buffet. When we go to an expensive restaurant and go off for the buffet, it's like that. So it's not a la carte menu, it's a buffet menu. So your patient of diabetes mellitus will have a huge burden of the microvascular and macrovascular complications. As we can see, 35 to 45% patients of heart failure have CKD. 20 to 44 patients of diabetes mellitus have CKD. 76% of diabetes mellitus and CVD patients have CKD. 2.2% of type 2 diabetes mellitus patients have coronary artery disease. Around 11% of that age group more than 15 years of age have diabetes mellitus, and around 15% of type 2 diabetes mellitus patients have heart failure. Essentially why we have moved on from the glucocentric approach to the cardio-metabolocentric approach, as we find in all the different guidelines. No matter what guidelines you look at, no matter the ADA guidelines, no matter the ADA AST consensus statement, no matter or the Endocrine Society position statement, or the AAC, American Association of Clinical Endocrinologists Association consensus statement, the world has moved on from that classical glucocentric approach to the cardio-metabolo-renal centric approach. And what we see, regardless of the patient's age, the all-cause mortality and cardiovascular mortality increased with increasing glycosylated hemoglobin. Look into your charts, it's very evident. The blue one is the all-cause mortality. If your patient has an HbA1c of more than around 6.5, yes, look at the blue ones, it's a very high. And the cardiovascular mortality also rises manifold with the rise in the glycemic burden. Be it the cardiovascular mortality, in fact, after the rosiglitazone controversy, the Vioxx controversy as we like to call it, of course, US FDA required dedicated cardiovascular outcome trial for all new agents for the management of diabetes mellitus, and in fact it has proven to be boon. Now not only have we the class of antidiabetic agents known as the gliptins, that is the DPP-4 inhibitors, most of whom, with the rare exception of the saxagliptin, which we will discuss, have proven safety as far as the 3P MACE goes. And the 3P MACE is the major adverse cardiovascular events, that is the cardiovascular mortality, non-fatal stroke, non-fatal MI. We usually have the fourth component of hospitalization due to heart failure. So more often than not, no matter what DP4 inhibitors, be it the linagliptin, we also have studies pertaining to sitagliptin. We don't have dedicated cardiovascular outcome trial with vildagliptin or teneligliptin, which we shall discuss. And not only that, the newer class of agent like the SGLT2 inhibitor, where the very prominent member is the empagliflozin, which is also our topic of interest. Not only the cardiovascular safety of the molecule is proven beyond doubt, but also the benefit, so much so that in almost all guidelines, depending on the patient of the patient's ASCVD risk or the renal risk or the presence or absence of microalbuminuria or macroalbuminuria, the presence of heart failure, where the target is weight loss, in most such cases, essentially amongst the oral agents, the SGLT2 inhibitors have a very prominent place now. And of course, if you're looking at the injectable agents, the GLP-1 agonists have a very important role to play. In fact, when I was going to the question and answer, I did find one question pertaining to oral semaglutide, the very new oral GLP-1 agonist that we have. But we will try to stick our discussion to the combination of DPP-4 inhibitor and SGLT2 inhibitor, which is a very attractive option, particularly this fixed dose combination of empagliflozin and linagliptin. Moving on, so the paradigm shift in the management of type 2 diabetes mellitus over time, we've moved on from the glucocentric approach to the events reduction approach, that is the cardiovascular metabolo-renal approach, and why that is essential. So we target our early management to prevent complications. We do know, of course, about the legacy effect of diabetes mellitus. To prevent long-term complication, you need to control the glycemic burden and you need to control it fast, because your diabetes mellitus has the legacy effect. If you are taking a great deal of time in achieving your control, the incidence and prevalence of complications increase. How badly? Even with 1 year delay in attaining euglycemic status, the very high increase in the morbidity and mortality burden is something that we are going to discuss, as we can see from the next few slides. So what happens if you delay in treatment intensification, and how it increases the risk of cardiovascular events in patients with type 2 diabetes mellitus. So a retrospective cohort study of 105,477 type 2 diabetes mellitus patients from UK data from 1990 with follow-up until 2012. Look at the mean HbA1c 8.1. and 11% had a history of cardiovascular disorder. Newly diagnosed type 2 diabetes mellitus, 22% remained under poor glycemic control over 2 years, 26% never received intensive therapy. And what does it show? 1 year delay in receiving intensive therapy in patients with an HbA1c more than or equal to 7 increases the risk of myocardial infarction by 67%. 1 year delay in receiving intensive therapy in patients with HbA1c more than or equal to 7 increases the risk of heart failure by 64%. 1 year, 64% higher risk. 1 year delay in receiving intensive therapy in patients with HbA1c more than or equal to 7%. 51% increase in the risk of stroke. 1 year delay in receiving intensive therapy in patients with HbA1c more than or equal to 7%. 62% increase in the risk of cardiovascular event. It is that bad. As is customary, we'll look at this case, this hypothetical case. We might also call it the index case, which will be our basis for understanding the impact of early initiation of fixed dose combination in type 2 diabetes mellitus. So our patient, this is a 55-year-old woman bank employee diagnosed with type 2 diabetes mellitus 5 years back. Patient has hypertension, hypercholesterolemia, has breathlessness for the past 1 week. Admits poor adherence that she complains from difficulty in taking our medications. What is the current therapy? The patient is getting metformin and sitagliptin 50 BD. Well, the patient really should be getting sitagliptin 100 once daily. And what else she is getting? She is getting enalapril 5 mg OD, probably as an antihypertensive. But if heart failure is a part of our ailment, including but not limited to diastolic dysfunction, as also systolic dysfunction, there also ACE inhibitors are important molecules for reducing mortality pertaining to failure and prevents cardiac remodeling. Also, she is getting simvastatin 40 mg OD. She is more than 40 years of age. She has diabetes, so every indication for the statin therapy. Look at the HbA1c, it's 7.9. Her age is only 55. She has only 5 years of diabetes, and this definitely is way beyond target. 7.9 is not an acceptable target in this lady. Of course, had she been a very old lady with a very high risk of hypoglycemia, multiple previous admission because of hypoglycemia, CKD, yes, we could have looked at maybe 7.9, but clearly in this lady, 7.9 is way beyond target. Look at the EGFR. Yes, it's less than 60, so CKD stage 3. HOMA-IR, well, 2.6. One thing to clarify, HOMA-IR is a laboratory tool, it's a research tool. HOMA-IR should never be prescribed as a routine practice by primary care physicians like me. It should never be done. It's a research tool. There is no point in diagnosing insulin resistance. It should never be advised. HOMA-IR. Patient was advised ECG and 2D echo. And what did we find? Because we want to find out the cause of the breathlessness. What we can see, look at the ECG very clearly. You can find a left ventricular strain pattern. Look at the in V5 and V6. Clearly, you can see the inverted T as also with voltage criteria meeting left ventricular hypertrophy. That is the S1 plus the R5, V5R or the V56 you added, it's more than 35. So tall R waves in the lateral leads, deep AS waves in the septal leads, and changes of the endocardial strain pattern. Clearly there is left ventricular strain pattern, and yes, so the results are out. On further investigation, our patient presents with ECG changes suggestive of signs of subclinical left ventricular hypertrophy. 2D echo, look at this, the left ventricular ejection fraction is 60%, and UACR is 200, so there's evidence of microalbuminuria as well between 30 and 300. So what are the issues with this patient? So subclinical cardiovascular disorder signs of left ventricular hypertrophy, renal concerns with albuminuria and dwindling EGFR values. You see that the EGFR is less than 60. Multiple comorbidities that are there. Patient is diabetic, patient has hypercholesterolemia, patient has hypertension, patient has left ventricular hypertrophy, and adherence is a concern along with the pill burden. So what are the options to address the concerns for this patient? add a sulfonylurea, which will of course improve the glycemic control, but we do not have any sulfonylurea that has a proven benefit in coronary artery disease, that has a proven benefit in mitigating ASCVD risk, that has a proven benefit in mitigating renal risk, there is a proven benefit in reducing macroalbuminuria progression, in reducing microalbuminuria progression, and so on and so forth. Would you want to add an SGLT2 inhibitor only? Yes, of course, SGLT2 inhibitor is a very attractive choice in such a patient. But would you want to add it? Patient is already getting a sitagliptin, but we know there is no fixed dose combination of sitagliptin with a SGLT2 inhibitor. Would we want to add the option 3? Would we want to add a fixed dose combination with SGLT2 inhibitor and DP4 inhibitor, which could possibly be a very attractive choice? Add a GLP-1 receptor agonist, very pertinent option as well, or add basal insulin. Well, the patient is getting only two drugs. The patient is getting metformin and sitagliptin, usually but not always. 3-drug failure would be an excellent place to add basal insulin, but the patient is getting only 2 drugs, and that too metformin only 1000 per day, 500 BD. So in such scenario, what would we want to do? Well, I'll just shift this slightly. Albuminuria and the risk of cardiovascular events and mortality in general population of patients with type 2 diabetes without cardiovascular disease, a Danish cohort study, and what does it show? Right. Albuminuria level is associated with cardiovascular events and mortality in patients with diabetes. However, little is known about the association between albuminuria level in diabetes patients without overt cardiovascular disease. So aim is to examine the association between albuminuria level and the risk of ischemic stroke, myocardial infarction, and the all-cause mortality in patients with type 2 diabetes mellitus without overt cardiovascular disease. The study population approximately 70,000 patients from a Danish registry from March 2005 to June 2015. Patients were followed for the outcomes ischemic stroke, myocardial infarction, and all-cause mortality. So essentially, these are the components of the 3 PMAs that we use in dedicated cardiovascular outcome trial pertaining with the US FDA recommendation for dedicated cardiovascular outcome trial for all new anti-diabetic agents. Albuminuria level was based on 2 consecutive measurements of the urinary albumin excretion rate, or the ACR. Well, the patients were divided into groups of the normoalbuminuria, microalbuminuria, and the macroalbuminuria. And what did we find? Well, ischemic stroke. And for your convenience, I'll annotate this a bit. Right. And what we see? Now, firstly, look at the microalbuminuria, the benefit. Yes. What is the hazard ratio? It's 1.4. So, and the confidence interval does not include 1. So, 40% lesser risk. Macroalbuminuria, yes, 2.33 hazard ratio. So, absolute risk reduction 1 minus 2.33 minus 1, that is 1.33, that is 133%. And the confidence interval also does not include 1. I mean, see, look at this. This is so far away from the hazard ratio of 1. The microalbuminuria, once again, 1.34. So the absolute risk reduction is 34%. Macroalbuminuria, absolute risk reduction 102%. 2.02 minus 1 is 1.02, that is 102%. In all cases, look at it, is not crossing over the hazard ratio of 1. Here also, macroalbuminuria, yes, 99% absolute risk reduction. In terms of all-cause mortality, look at this, 52% reduction in all-cause mortality, 103% reduction of macroalbuminuria, 83% reduction of macroalbuminuria as a cause for all-cause mortality. I mean, we can go on and on, but clearly the values are self-evident. Moving on. So the study showed that albuminuria level is associated with a higher risk of incident of ischemic stroke, myocardial infarction, and all-cause mortality in type 2 diabetes patients without overt cardiovascular disease. Well, we look at the different molecules, the cardiovascular and renal outcomes with the SGLT2 inhibitors. Empagliflozin shows consistent reduction in all cardiovascular and renal outcomes, and this is important. What about, what is the classical dedicated cardiovascular outcome trial of empagliflozin? It is the EMPA-REG. Of course, subsequently we had the EMPEROR-R and so on and so forth. We had the EMPA-PRESERVE as well. But what about the EMPA-REG? Well, hospitalization due to heart failure, the hazard ratio is 0.65. So, 35% relative risk reduction of hospitalization due to heart failure. If you look at all the other molecules, if you look at canagliflozin, what is the dedicated cardiovascular outcome trial? It is CANVAS. We also have the creatine subsequently. Declatimine is for dapagliflozin. Here also, what is the hazard ratio? 0.73. So the relative risk reduction is 27%. For artugliflozin, the verticili, for hospitalization to heart failure, the 30% absolute risk reduction. Issue is, only in hospitalization due to heart failure do we have mortality benefit. You have absolute risk reduction with a statistical significance for all the four molecules. But if you're looking at cardiovascular death only in case of empagliflozin, you have a statistically significant absolute risk reduction. The hazard ratio is 0.62. If you look at the confidence interval, it does not cross 1. But if you look at CANVAS, if you look at declatimine, you look at verticili, look at the confidence interval. In each case, the confidence interval is crossing over 1. It is not a statistically significant finding. If you look at 3P MACE, well, the outcome benefit is for canagliflozin and empagliflozin, not even for dapagliflozin, but as far as 3P MACE is concerned. If you look at the renal outcome, well, for renal outcome, empagliflozin and canagliflozin and dapagliflozin, all of them show significant, statistically significant improvement, but not artugliflozin. Remogliflozin, it's a molecule as we know in the Indian market, and there's a lot of noise about it, but there's no dedicated cardiovascular outcome trial for remogliflozin. I really would want to go in depth about remogliflozin. It is not a molecule with a dedicated cardiovascular outcome trial. Now, empagliflozin demonstrates significant benefits across the cardiovascular renal metabolic axis in type 2 diabetes mellitus patients. 3P MACE reduced by 14%. Look at the p-value. P-value is significant. Death by any cause reduction by 32%. The p-value is significant as well. Cardiovascular death, we found that the hazard ratio was 0.62. So 38% reduction in cardiovascular death. Nephropathy, we found that the hazard ratio was 0.61, so 39% reduction in nephropathy. And renal compromise, the hazard ratio was 0.54, so 46% renal composite outcome that we found. Well, we'll look at the cardiovascular and the renal outcomes pertaining to the DPP4 inhibitors, and Linagliptin has ample evidence and is safe across all cardiovascular and renal outcomes. We are of course talking about the safety. Added benefit is not there with any of the DPP4 inhibitors, but look at saxagliptin. This is the SAVOR team 53, and what is the data? The hazard ratio is 1.27. So, and look at the confidence interval. It is more than 1, it does not cross over 1. So, in fact, saxagliptin increases the risk of hospitalization due to heart failure by 27%. Well, you look at Carolina, linagliptin, well, hospitalization due to heart failure and cardiovascular death and 3P MACE and renal outcome, all of them show a statistically non-significant change compared to add-on placebo. Well, vildagliptin, there is no dedicated cardiovascular outcome trial. VIVID trial, we know, gives evidence of increased left ventricular volume, and VERIFY, of course, is a trial for early initiation of vildagliptin metformin combination. So neither VIVID nor VERIFY is a trial, is not a dedicated cardiovascular outcome trial. And as far as linagliptin is concerned, another very popular molecule, possibly because of its cost. It once again doesn't have a dedicated cardiovascular outcome trial. There is a risk of prolonged QT interval, increased risk of torsitis de pointis, also an increased risk of pemphigus vulgaris. So increasing UACR and increasing eGFR play a huge role in CKD progression. In CKD progression, as we know, findings from the KDIGO, the combination of an increase in UACR and decrease in eGFR is strongly associated with the risk of advanced CKD and should be further studied as an alternative outcome in CKD clinical trials. As we can see the data present here as well. So empagliflozin trials provide benefits on both hard kidney outcomes and the surrogate endpoints, be it albuminuria, be it eGFR, be it the hard kidney outcomes. Very significant finding with empagliflozin. Carmelina. Carmelina included the highest proportion of patients with reduced kidney function compared with other cardiovascular outcome trial to date. And what we see, if you look at TACOS, it's a study for sitagliptin, as we know, hardly 22.7% patients had CKD. For examine, it's a study for allogliptin, around 30% patients had CKD. For sevatinib, saxagliptin, even lesser. Whereas Carmelina, more than 62% patients had CKD, that is a eGFR less than 60. Mind you, our index patient also had a eGFR of 58, so belongs to the criteria of CKD stage 3A. In Carmelina, Linagliptin was associated with significant reduction in albuminuria progression. Look at the hazard ratio. The hazard ratio is 0.86. The confidence interval does not include 1. The p-value is significant, it's less than 0.005. So what is the relative risk reduction? The relative risk reduction is 1 minus 0.86, that is 0.14. That is 14% risk reduction, which is statistically significant when you compare to add-on placebo. Yes, 14% reduction, as you can see. And 81% of the patients were already getting the ACE inhibitor, as would be a recommendation in any patient with microalbuminuria or macroalbuminuria, especially with diabetes mellitus. So the benefits of the combination, one importance is of course the metabolic, essentially the glucose reduction. HbA1c reduction approximately 0.8% with empagliflozin, approximately 0.7% with linagliptin. This is the glucose-centric target. Very importantly, we have discussed this previously, is that so the combination is 1.2 to 1.8%. Very importantly, multiple studies have shown very significant compared to our Caucasian counterparts in the Indian population, the HbA1c reduction is being significantly higher with the SGLT2 inhibitor in the Southeast Asian cohort. Same with DP4 inhibitor, significantly better compared to the Caucasian counterpart is a norm. So essentially the findings of this international clinical trials holds good, in fact holds better if we compare our Southeast Asian counterpart compared to the Caucasian cohort. Both empagliflozin and linagliptin are recommended in type 2 diabetes mellitus patients at risk for heart failure. Proven mortality benefit with empagliflozin in diabetes mellitus with ASCVD. It's a class 1 recommendation, the ESC/ESD consensus statement. EMPA-REG 39% relative risk reduction of incident or worsening of nephropathy in type 2 diabetes mellitus patients with ECVD. Carmelina shows 14%, as we saw, 14% relative risk reduction of progression to albuminuria in type 2 diabetes mellitus patients. What about the hepatic evidence? No dose modification required in hepatic impairment with both empagliflozin and linagliptin. In patients with type 2 diabetes mellitus and in FLD, empagliflozin significantly reduces liver fat and improved hepatic enzymes, as we find from the ELIFT study. The randomized controlled trial evidence with the SGLT2 inhibitor and the DP4 fixed dose combination in India. Well, for empagliflozin, the dedicated EMPA-REG outcome reduces 3P MACE, reduces CV death, reduces hospitalization due to heart failure, reduces the renal risk, reduces the progression of nephropathy, reduces the progression from microalbuminuria to macroalbuminuria, and similarly with linagliptin. In fact, linagliptin is a neutral for 3P MACE and cardiovascular death and hospitalization due to heart failure and renal also. In fact, 14% relative risk reduction in the progression of macroalbuminuria, and the dosing is once daily. When we compare dapagliflozin and saxagliptin, yes, so saxagliptin hospitalization to heart failure, we found that the hazard ratio was 1.27, statistically significant as well. You cannot give it in a patient of heart failure. Empagliflozin and vildagliptin, we know such a combination is available in the Indian market. Recommendation is twice daily. Neither empagliflozin nor vildagliptin has a dedicated cardiovascular outcome trial, so it does not have dedicated data pertaining to the reduction of 3P MACE. that is major adverse cardiovascular event, that is cardiovascular mortality and non-fatal MI and non-fatal stroke and cardiovascular death and hospitalization to heart failure and renal risk and the progression of microalbuminuria or macroalbuminuria or reduction of EGFR. There is no dedicated data pertaining to either of Linagliptin or Vildagliptin. So the metabolic cardiovascular continuum, as we keep on discussing, the common soil of risk factors would be hypertension and diabetes and obesity and hyperlipidemia, leading to atherosclerosis and ventricular hypertrophy, endothelial dysfunction, macroalbuminuria, which will ultimately cause the major events like the end-stage heart disease and the end-stage renal disease and the cardiocerebrovascular death, which we usually study, that is the 3P MACE and the CKD progression. An EMPA-LINA fixed dose combination provides risk modification at every stage of the continuum. There is a robust HbA1c reduction up to 1.8 with the two molecules, significant pleiotropic benefits, weight and BP reduction. In some studies, double-digit BP reduction. Always note that your empagliflozin, for that matter, any SGLT inhibitor, it's not an anti-hypertensive drug. So if your patient of diabetes mellitus also has documented hypertension, the patient should be on an antihypertensive drug as per protocol, starting with the ACE inhibitor ARB. If inadequately controlled, adding the second line calcium channel blocker. If inadequately controlled, to be on thiazide like diabetes, example being chlorthalidone or indapamide. If still inadequately controlled, check the potassium value. If the potassium is more than equal to 4.5, put the patient on alpha blocker or beta blocker. If the potassium level is less than 4.5, put the patient on mineralocorticoid receptor antagonist. But kindly note that it is the pleiotropic benefit of the SGLT inhibitor. The major adverse cardiovascular event and heart failure benefits with empagliflozin is clearly proven from the EMPA-REG. We also have now data pertaining to the use of empagliflozin in non-diabetic patient with heart failure even with preserved ejection fraction. We previously had data pertaining to heart failure with reduced ejection fraction. We now have data of empagliflozin of heart failure with preserved ejection fraction as well. And we have adequate safety data with Linagliptin from Carmelina, which had approximately 62% patients with CKD, that is EGFR less than 60, and 14% reduction of macroalbuminuria incidence with Linagliptin as found from the Carmelina, which is statistically significant as well. So essentially makes this a very attractive option. Now, does this impact the cost effectiveness of empagliflozin plus Linagliptin fixed dose combination in long-term management of type 2 diabetes mellitus patient? So what is the cost of diabetes in India? I mean, at the end of it all, no matter how much we discuss, we tend to think of the empagliflozin Linagliptin combination as a expensive medical option. Is it really expensive? In a classical Indian patient, what is the cost of medicine? What is the cost of investigation? And what is the cost of complication? And the cost of complication ultimately measured in quality of life or disability adjusted life year tally. So how does it add up? And this is something that we shall see. Diabetes related treatment, only 28% is the diabetes related treatment. So if you are not controlling 3P MACE, if you are not reducing the risk of hospitalization due to heart failure, if you are not reducing the risk of hypoglycemia, if you are not reducing the risk of weight gain and subsequent metabolic derangements, if you are not reducing the risk of ASCVD risk progression, then what is the outcome? So the treatment of complications and hospitalization is around 23%. Monitoring and screening for complication 36%, other cost 8.7%, indirect cost on unemployment losses 4.3%, and cost of FDC is lower than the individual agent. As we know, if the patient is getting empagliflozin 25 separately and linagliptin 5 separately, then the cost of the combination is less than the sum total of the counterparts by 25 to 30%. Significant reduction in cardiovascular death, as we found. So the hazard ratio was 0.62, so 38% risk reduction. Hospitalization due to heart failure, hazard ratio was 0.65, so 35% risk reduction. Significant albuminuria benefit with linagliptin, 14% relative risk reduction. The hazard ratio was, as we found, was 0.86. The combination produces an HbA1c reduction between 1.2 to 1.8%. In fact, we remember our index patient had a HbA1c of 7.9. So reducing it by approximately 1.5 to 2 would actually be the target. So what are the recommendations for this patient? Replace the DP4 inhibitor with the empagliflozin and linagliptin fixed dose combination. Increase enalapril to 10 mg OD because the patient had an inadequate control of hypertension. Support a diet and exercise program to reduce body weight. Explore reasons for non-adherence. Monitor for further kidney function decline. So hyperglycemia associated with oxidative stress and or reactive oxygen species is the main cause of the diabetic nephropathy. The EMPA-LINA fixed dose combination, evaluate whether the EMPA-LINA fixed dose combination reduces the renal oxidative stress evoked by the chronic hyperglycemia. This is of course an open label randomized control trial, and the objective of this randomized control trial was to evaluate the effect of empagliflozin linagliptin on reactive oxidative stress in type 2 diabetes mellitus patients with CKD stage 3 patients. And what did this randomized control trial find? Inclusion criteria as would be the norm, and to evaluate the renal oxidative stress with the biomarker measured by urine 8 hydroxy 2-proyl deoxyguanosine and renal biomarker by urine albumin creatinine ratio. So what is the finding? You can see that the eGFR is between 30 and 59. The patients had CKD. HbA1c reduction. Look at the HbA1c reduction with the combination, approximately 1. In the control group, only around 0.4. The renal biomarker reduction, 94 is the reduction, and the confidence interval does not cross 0. Whereas it's reduced, actually increasing in the control group with 65. So there is a worsening of the renal status in the control group. The renal oxidative stress biomarker, reduction by approximately 20 nanogram per microgram. Whereas in the control group, forget about decline, there is an increase in the renal oxidative stress biomarker. So the results suggest that the EMPA-LINA treatment for 12 weeks improves the renal oxidative stress and glycemic control in type 2 diabetes mellitus patients with CKD, which could play a key role in reducing the progression of diabetic nephropathy and appears to be well tolerated. In fact, the eGFR reduction and the eGFR progression is actually improved with the combination and actually worsened in the control group. eGFR, as we know, is now extended to 30. Previously it was 60, now extended to 30. Till 30 you can use the combination. Thank you so much. We are at the end of our discussion.